Thank you very much, sir, for an excellent talk and addressing all four pillars for congestive heart failure. Not only addressing the newer things, but also telling us that what is the role of vaccination, which is a new perspective or new thing in the treatment of heart failure. Sir, you have shown us various trials of dapagliflozin and empagliflozin. So I would like to ask you, how will we select between dapagliflozin and empagliflozin for treatment of heart failures?
That
On what grounds?
Question. The guidelines do not differentiate between DAPA and EMPA for treatment of heart failure. But there are certain differences. If you look at the DAPA-HF and the EMPA-reduced, DAPA decreased all-cause mortality by 17% and cardiovascular mortality by 17%, which was not shown by the EMPA-reduced trial. The reduction in new onset diabetes was also more with DAPA 32% versus 8%. So there are minor differences, but this is not a head-to-head comparison. So the guidelines do not differentiate. You can use DAPA or EMPA in patients with reduced ejection fraction and now also with preserved ejection fraction.
So there is one more question that we know that acute decompensated heart failure patients, when present with us, 30% of them have the abnormal renal function. So there is interplay between this heart and renal abnormalities. So how do we see and what precautions we should take while treating the patient who is presenting with cardiorenal syndrome, or what is the continuum of cardiorenal syndrome?
While treating heart failure, we must never forget to target cardiorenal continuum. If you treat heart failure alone without worrying about what the kidney component, the benefit will not be maximized. Never forget, treating CKD triggers benefit for heart failure. And interestingly, SGLT2 inhibitors target both the component of cardiorenal continuum. They decrease hospitalization for heart failure and also mortality. And they slow down the trajectory of CKD and postpone dialysis by 10 to 15 years, which is indeed a very great achievement. So both the components should be targeted, right, please.
So if a patient of heart failure improves with the drug therapy that's been given at the outset, so do we de-escalate the dose of the drug once the patient has improved?
Never forget, heart failure is always an unstable condition. Never try to de-escalate therapy. Always escalate unless side effects preclude their incrementation in the dose. The only two exceptions are peripartum cardiomyopathy and Takashimbo cardiomyopathy, where you may attempt to de-escalate, but that de-escalation should only be given not merely on the basis of reduction in ejection fraction. The GLS has also to be shown to become normal. Then only you may attempt, but you have to. But otherwise, we never recommend de-escalation because heart failure only goes into remission. It is not cured. So always maintain the therapy. There are these two exceptions where you may think, but the TED-HF trial showed that if you de-escalate, many patients do not show the improvement which they were showing before de-escalation. So always try to maintain, except under certain circumstances.
I'd just like to make a small comment, I think, because we have seen a lot of patients of COVID cardiomyopathy, and most of them, they improve completely. That's why there is a radical reversal of cardiomyopathy under remodeling. And number two, septic cardiomyopathy. A lot of patients of septicemia, they also have a complete reversal of the remodeling. So these are the two additions, but we need more data. And I think a lot of data is coming up in cardiomyopathy. In my own experience, I've got 9 patients of COVID cardiomyopathy, completely reversed. And we have to de-escalate and they're doing well. I'm going to stop them because they're inflammatory. So inflammatory pathology easily reversed as compared to non-inflammatory. These two, we need more data. But I think Dr. Panoria has given a very beautiful outlook that two entities, especially increased epinephrine, norepinephrine liberation, reversal is 100%, as well as in peripartum. But these two have to be added in the due course of time.
And thank you very much, Chairpersons Dr. Padma Sri Gulati and Professor Dr. Girish Barma to spend your valuable time here. And also the Dr. P.C. Manoria, our senior eminent speakers.